So I will be talking about approach to selection of patients for rTMS and setting protocols for evidence-based protocols for rTMS. My previous speakers, they already discussed about the neurobiological basis of the mechanism of action of rTMS and the clinical indications of rTMS. Now I'll be talking, my presentation will be a bit of overlap of these previous two presentations, but I got the opportunity to continue my presentation because we are running fast. So we have enough time to discuss about the practical parameters of rTMS. So thank you, Dr. Shruti, for giving me additional time for this presentation. Regarding selection of patients for rTMS, our selection basically depends upon who are those patients who are suitable for rTMS. When we are doing a suitability assessment, we need to refer to what are the indications, what are the contraindications of rTMS. And there are a set of indications and contraindications. Coming to the indications can be broadly divided into two types of indications. There are indications that are approved by the FDA and other agencies. And there are some indications that are not approved by FDA. We call them the off-label indications. So the FDA approved indications are already been discussed. The first indication for which rTMS got approval by the FDA was depression in 2008. Subsequently, multiple other psychiatric conditions like OCD, like smoking, different protocols of rTMS, like coming from conventional TMS to intermittent theta burst stimulation, deep TMS, they got approval by FDA. So when we are talking about approval of rTMS by FDA, what exactly it refers to? Not all the machines are approved by FDA, not all the coils are approved by FDA, not all the target areas are approved by FDA, and not all the protocols are approved by FDA. There are various protocols. So FDA gives approval to a particular machine, to a particular coil, to a particular target area, and to a particular protocol. So it is very specific. Suppose we use a particular coil of a particular machine, and that is being approved for depression, that you cannot generalize for other psychiatric illnesses. That coil may not be approved by FDA for OCD, may not be approved by FDA for smoking or other psychiatric conditions. So it is not a blanket approval. It is a very precise approval for a particular coil, for a particular machine, for a particular protocol, and for a particular target area. So we need to understand this. Now there are many regulatory clearances and approvals for therapeutic protocols of TMS in various psychiatric disorders. Some of the protocols are using conventional TMS, and some of the protocols are using the newer version of TMS, that is deep TMS and theta burst stimulation. My presentation will basically focus on more of a conventional TMS because of paucity of time. But to give you an overview about, for the condition major depressive disorder, the primary target area is left dorsolateral prefrontal cortex if you are using a stimulatory protocol. Stimulatory protocol, basically I refer to a protocol of high frequency protocol, or if you are using theta burst stimulation, then intermittent theta burst stimulation will be a stimulatory protocol. But you can target right dorsolateral prefrontal cortex as well, but that is not approved by FDA. If you are targeting right dorsolateral prefrontal cortex, then the protocol will be an inhibitory protocol. You can go for the low frequency rTMS, or you can go for the continuous theta burst stimulation. People have tried with bilateral dorsolateral prefrontal cortex, particularly when they are using the H1 coil, which is a deep TMS. It gives bilateral dorsolateral prefrontal cortex, particularly targeting the inferior frontal gyrus, insula part. They are also involved by this neuromodulation facility, that is deep TMS, H1 coil. When there is comorbid anxiety, depression with comorbid anxiety, then bilateral DLPFC may be useful, particularly people who are using deep TMS using the H1 coil, they can refer to that. Even you can target the left dorsolateral prefrontal cortex alone. That is a single cortical target. Coming to OCD, actually OCD causes involvement of the striatal structures. Striatum is deep seated, and the striatal connectivity to anterocingulate cortex and medial prefrontal cortex, they can be They are also deep seated, so they cannot be reached by the conventional rTMS coil. So H7 coil of deep TMS can give a penetrability to the deeper regions, particularly the anterocingulate cortex and medial prefrontal cortex. But if you are using conventional TMS, you can modulate the cortical activity of the functionally connected areas of the striatum, that is supplementary motor area and the pre-supplementary motor area. So that can be modulated. Even DLPFC is another target of OCD. I will be coming to the evidence in favor of the different areas when I will be talking about OCD in detail in subsequent slides. Smoking cessation is a recent approved condition that uses H4 coil, particularly it is bilateral inferior prefrontal gyrus, prefrontal cortex. It has been targeted by S4 coil by using deep TMS and recently approved by FDA for smoking cessation treatment. Coming to the summary of recommendation, that FDA has approved the level of evidence for high frequency rTMS over left DLPFC is the level 1 evidence, the highest level of evidence. We have evidences of randomized controlled trials, double blind randomized controlled trial, and the systematic reviews and meta-analysis on that. So that is the most highest level of evidence. We have evidence for that. When we are talking about low frequency rTMS targeting right dorsolateral prefrontal cortex, again, we have several double blind randomized controlled trials. So level B evidence, which is also a very good evidence. When we are talking about unipolar depression, the level of evidence is the highest level of evidence, that is level A. When we are talking about PTSD is another indication where anxiety symptoms are very prominent and autonomic arousal are quite prominent. High frequency rTMS targeting right DLPFC can be one potential way to deal with PTSD. So the level of evidence is level C. It's more of randomized control trials or open level trials. They come in this category. If you are targeting auditory hallucination, particularly persistent auditory hallucination in schizophrenia, then the target area is left temporoparietal junction, that is T3P3 junction. So level of evidence is level C. If you are targeting the negative symptoms of schizophrenia, then high frequency rTMS targeting left DLPFC is the target. Level of evidence is level B. We have well conducted double blind RCTs, several RCTs conducted in several regions of the globe. Addiction is another emerging area where possible effect of high frequency rTMS over left DLPFC in smoking and alcohol use disorder as well as in cocaine use disorder. So there are some emerging evidences. The level of evidence is level C. Now there are other psychiatric indications which are not approved by FDA or other competent agencies who deal with giving approval for devices for use in various neuropsychiatric conditions. One of the condition is neurocognitive disorder. Particularly, the evidences are more in favor of Alzheimer's disease and post-stroke cognitive decline. And there are some evidences the cognitive decline associated with Parkinson's disease. So these are the conditions where neuromodulation like TMS can be used, and the common target area being the left dorsolateral prefrontal cortex. People tried with high frequency rTMS ranging from 10 Hz frequency to 20 Hz frequency. Then cognitive symptoms of schizophrenia is another potential target of neuromodulation. There again the same target area, left dorsolateral prefrontal cortex, using the high frequency rTMS. Eating disorder is not much studied area, much studied condition, but there are several studies that talk about the evidence of rTMS in eating disorder. There are some important target areas. I will be talking about those target areas when I will talk about eating disorder in detail. The common target area, people say that eating disorder is a phenomenon. There is a lot of cognitive errors associated with self-image, a lot of cognitive error associated with body shape, and usually patients with eating disorder, they have comorbid depression and anxiety symptoms. So the potential target area becomes the left dorsolateral prefrontal cortex. Another model of explanation for eating disorder. It's more of a compulsive ritualistic phenomenon of eating or purging. So this can be more of a in the spectrum of compulsive phenomenon, obsessive compulsive phenomenon. If that goes in that direction, then orbitofrontal cortex and the supplementary motor area can be another potential target area. So people have tried those areas. ADHD, autism are the commonly used, commonly neurodevelopmental disorders that are been targeted in using rTMS. There are some preliminary evidences, though there is no FDA approval or approval by any competent agency to use it as a recommended modality of treatment. That there are when to avoid rTMS. There are several contraindications. There are some common side effects that Dr. Shruti and Dr. Anurag has already discussed. That pain, headache, neck pain. These are the common side effects reported by patients with who are receiving TMS. Usually, the symptoms are mild and self-limiting, and does not require discontinuation of rTMS. Mostly self-assurance and more of some procedural adjustment, and more of if the pain is not tolerable, a short course of analgesics can be enough in dealing with these issues. But sometimes, rarely, patient they report with some serious side effect like seizure, but the incidence is quite low, just like the risk of Epstein anomaly with lithium. It's quite rare. So similarly, risk of seizure with rTMS is very rare. So it's a very uncommon phenomenon, but we need to be prepared for that, particularly in those individuals who are having a history of seizure in the past, those who are taking some medications which are having some pro-convulsive effect, like clozapine, like clomipramine or tricyclic antidepressants in a high dose, or those patients who are having receiving rTMS with a high frequency protocol. High frequency protocol is having a tendency to cause seizure-like activities in some of the patients, or those patients who are having a significant sleep impairment that can reduce the seizure threshold and they increase the risk of seizure. In those individuals, you need to be very much cautious. There are some clear contraindications to rTMS, particularly those individuals who are having cochlear implants, and those individuals who are having some metallic device, particularly ferromagnetic device, iron, copper, or nickel containing device, at least within 10 centimeter from the target area. Because the penetrability maximum strength of magnetic field is around 2 to 3 centimeter from the point of maximum field of electric, from the center of the coil. But the magnetic field can extend up to 10 centimeter if there is a pacemaker in the neck, particularly somebody is receiving vagus nerve stimulation. If there is a cochlear implant, if there is a metallic thing in the around the neck, so that may influence. Suppose somebody is having a central vein catheter is given, and suppose somebody is undergoing for deep brain stimulation, an electrode is already placed over the scalp. So it may alter the pulse generation in that particular area. So it is better to avoid. These are contraindications for use of TMS. Particularly when you are talking about the pediatric age group, majority of the studies, they excluded pediatric population. That's why the evidence in pediatric population is quite sparse. However, there are evidences, particularly in population or adolescent population. So whatever the evidence, they say that if there is a ferromagnetic material, intracardiac line, intracranial pressure is high, these are some contraindications. Suppose somebody is having a raised intracranial pressure and there is a ventriculoperitoneal shunting is there. So in those scenarios, it is better to avoid rTMS. So we are talking about how to select the patient. We select the patient on the basis of if there is a contraindication, we need to avoid. If there is an indication, then we need to think whether there is a contraindication or not. So it is all about thinking contraindications and indications. Now talking about when to consider rTMS. Can we consider rTMS as a standalone treatment? Can we start rTMS early in the course of treatment as a add-on therapy, which call as early augmentation of rTMS? Can we use rTMS only for the treatment resistant cases? Mostly the recommendations, they talk about treatment resistant cases. If you are talking about depression, OCD, all those cases, the evidence is the recommendation is you use rTMS if there is a failed trial of antidepressants, multiple trial of antidepressant and psychotherapy in depression, and multiple anti-obsessive medications has been tried in the treatment of OCD, and the behavioral intervention like exposure response prevention has been tried and unsuccessful. In those scenario, you can consider rTMS, but it is not a hard and fast rule to wait for treatment resistance. You can, there are some evidences that you can start early in the course of treatment. You can start rTMS as an add-on treatment. So in that scenario, the evidences support that if you start rTMS early in the course of treatment, probably you will be able to control the symptoms early. You can, the patient can resume the functionality early. You can limit the disability, and there are so many advantages in terms of the outcome of the illness. So early augmentation can be one way of introducing TMS in the treatment area. Now the thing is, can we use rTMS as a standalone treatment? It totally depends upon the type of indication for which you are using. Suppose you are using it for depression or OCD or schizophrenia. There are many patients who are intolerant to the conventional modality of pharmacotherapy. They don't, we have used, in my personal experience, we have used uh, TMS as a standalone modality of treatment in few of the patients, particularly those who are OCD and having OCD. They have severe intolerance to serotonergic medications. So they were not able to tolerate the medications. We cannot optimize the dose of medications. So we started with rTMS. And during the acute phase of treatment, the symptoms are adequately controlled. But the after effect of TMS after multiple sessions usually wins off over a period of 8 to 12 weeks. So we require maintenance treatment for the continuous control of those symptoms. So these are the conditions where you can consider as a standalone treatment. It can be considered, but the evidences are quite few, because mostly people use rTMS as an add-on treatment to the ongoing pharmacotherapy or psychotherapy. It can be started early in the course of treatment, but most of the evidences, they exist with respect to treatment resistant psychiatric disorders. It is used for the acute management of the symptoms. In the acute phase, you give intensive therapy, at least one session per day, at least 5 sessions in a week, and total number of sessions at least ranging from 10 to 20 sessions continuously over a period of 2 to 4 weeks. That helps in acute control of the symptoms. But there are conditions where patients require a more number of sessions, particularly patients with OCD, patients with schizophrenia, particularly those who are having negative and cognitive symptoms. They require more number of sessions. Uh, some of these patients, after discontinuation of rTMS, the symptoms again relapse. Then you need to consider maintenance treatment of rTMS, maybe one session weekly or 2 sessions weekly. Subsequently, you can plan to space the sessions of rTMS. So maintenance rTMS is one good strategy to prevent the relapse of the symptoms. And in our rTMS clinic, we are using rTMS for prevention of relapse as a maintenance treatment, and a quite a good number of patients are there for maintenance treatment of rTMS. Now coming to safety of rTMS, it has been already been discussed by Dr. Anurag and Dr. Shruti that there are already safety screening questionnaires when you are using rTMS. That screening questionnaire need to be applied in every patient, whether there is any contraindication for rTMS or not. Those safety checklist is available in multiple, you can get it from multiple published articles. One of the initial article by Roji et al, Andre Brunoni and Roji, that they have the team, they publish a checklist. The mostly the contraindications of rTMS are similar to the contraindications of MRI, so you can refer to that. And rightly pointed out by Dr. Anurag that if somebody has undergone MRI in the recent past, fairly that person is fit for rTMS, you can go, because that person might have gone through that checklist of things before before going for MRI. Now we'll be talking about after selection of the patient, how to decide the stimulus dosing for different psychiatric conditions. The stimulus parameters particularly depend upon, you need to know about what is pulse, what is frequency, what are the number of pulses per sessions, what is the train, uh, total number of pulses, daily frequency of sessions, how many sessions you give in a day, how many total number of sessions you give at a go. So these are all the parameters that are important when you are deciding the efficacy and evidence of rTMS in various psychiatric disorders. When you are considering rTMS for a research purpose, you need to take all this data into account for doing the analysis for predicting the outcome. So in the afternoon, we'll be having the hands-on training demonstration, during which we'll be displaying how to regulate the pulse frequency, how to set the number of pulses per session, how to set a protocol, all those things will be discussed. But in brief, I will be telling that pulse frequency can be broadly divided into, when we're talking about conventional rTMS, broadly we divide the pulse frequency into high frequency protocols and low frequency. High frequency is if the frequency is 5 pulses per second or more, it is high frequency. And less than 5 hertz, mostly 1 hertz, 2 hertz and 0.5 hertz are the three low frequency protocols commonly being used. 0.5 hertz means 1 pulse in every 2 seconds. So low frequency particularly target the GABAergic neurons producing an inhibitory effect, whereas high frequencies particularly stimulate the glutamatergic neurons producing an excitatory effect. Next is the number of pulses per session. What are the evidences? There are some evidence-based guidelines, recommendations. The first evidence-based safety and clinical recommendation of rTMS is published in 2014 by Lafayette et al. In the Journal of Clinical Neurophysiology. That is a classic article that every individual who is planning for rTMS, everyone should read that article. Again, that the updated article is published in 2020. That is whatever the evidences existing between 2014 to 2018. So rTMS consensus guideline. Subsequently, in 2023, Brunoni et al. They have also published a safety and recommendation for use of TMS. The initial guideline, they support that to have an effective treatment with TMS, at least per session you need to give 1000 pulses per session. So 1000 pulses or more pulses in a session, in a given session, is found to be more effective consistently. Then the number of pulses per train totally depends upon whether you are choosing a high frequency protocol or low frequency protocol. Suppose you are giving a high frequency protocol, particularly 10 hertz frequency, you cannot give more number of pulses. You need to restrict to 40 to 60 pulses in a given train. So if you give more number of pulses with high frequency, then there is a risk of seizure. So one need to be cautious. But if you are giving a low frequency stimulus, that is 1 hertz, 2 hertz or 0.5 hertz, then you need to, you can keep more number of pulses in a train. Then again, the inter-train interval. So what is a train actually? Pulse is a single stimulus, a single magnetic stimulus. When you are delivering a stimulus, you will hear a tick sound. That tick sound corresponds to one magnetic stimulus. So the pulses are released in a sequential manner. So pulses are released in bunches. So you release 40 pulses simultaneously at a given frequency, then you give a gap. That gap is the intertrain interval. Again, then 40 pulses will come. Then there will be a pause or a gap. Again, 40 pulses will come. Then there will be a gap. Why I am talking about 40 pulses? Because this is the first US FDA approved protocol in 2008 for depression. They have used 10 hertz frequency, 40 pulses in a train. So 4 seconds will deliver 40 pulses with 10 hertz frequency. Then a 20 second of intertrain interval. A total of 75 trains. Each train delivers 40 pulses. So 75 trains will deliver 3000 pulses over a period of 37.5 minutes. So that was a long train that is approved by US FDA high frequency protocol at 120% of the resting motor threshold over left dorsolateral prefrontal cortex. So when you are giving a high frequency protocol, you need to keep the intertrain interval bit large so that the neurons will reach a refractory to a stimulating pre-refractory state, and they will respond to the stimuli. And second thing is there will be minimal side effect. That is, you can minimize the risk of side effect like seizure. But if you are giving a low frequency protocol, you can keep the intertrain interval shorter, as short as 5 seconds. Then total number of pulses, it is another indicator of treatment outcome. If you give more number of pulses, it gives a better outcome. There are some early evidences, but more research is required to substantiate these evidences. The evidences support that if you give, suppose somebody is receiving 10,000 pulses over a period of 2 weeks over 10 sessions, and somebody is receiving 20,000 pulses over a period of 2 weeks over 10 sessions. So if you are giving more number of pulses, total number of pulses, then the outcome is likely to be better. Then there are different frequency of protocols. Conventional protocols, they recommend 1 session per day, at least 5 to 6 sessions per week, and roughly a 10 to 20 sessions in total over a period of 2 to 4 weeks. When you refer to most of the Western literature, Western studies, most of the studies, they did 5 sessions in a week, because there are 2 weekdays that are weekend days. The TMS is not being delivered, so they usually classically deliver 5 days a week session. But there are many setups where the setup is open all the 7 days or 6 days a week. So it is not a contraindication that you cannot give 6 sessions in a week or 7 sessions in a week. You can do, but 5 to 6 sessions are mostly evidence based supported sessions, 5 to 6 sessions in a week when you are following a conventional procedure, 1 sessions daily. Then if you are giving more, you can give more than 1 sessions in a given day. That is classically called as accelerated protocol. In our center, we have given mostly we give accelerated protocol to curtail the duration of treatment. So as I was talking about the stimulus dosing parameters. So coming to the number of pulses, then daily frequency of sessions. Accelerated protocol is mostly more than 1 session per day. It can be safely delivered. Very recently, the Stanford protocol, that is by the Saint protocol, that is approved during 2020. It gives that you can give more than around 10 sessions in a given day, and a total of 50 sessions over a period of 5 days. So it is found to be quite safe and US FDA approved. So accelerated protocol can go up to 10 sessions in a given day. The total number of sessions, conventionally it is across the studies for various psychiatric disorders, they used 10 to 20 sessions over a period of 2 to 4 weeks. But you can extend the number of sessions beyond 20. If you are extending beyond 20, it is called as an extended protocol. If you are giving 20 daily sessions over a period of 4 weeks and beyond, more than 20 daily sessions. So extended protocol is required for particularly those individuals who are having long-standing refractory depression, individuals who are having negative symptoms of schizophrenia, and particularly patients with refractory OCD. Now there are some tasks for the audience, but because of the time paucity, I'm skipping all those things. I may skip few more slides in between because they are being discussed by the previous 2 speakers. So when you are talking about setting a protocol, it is important to understand the resting motor threshold. Resting motor threshold is every individual is having a different resting motor threshold. This is the threshold at which the 50% of stimulus are being responded by the neurons. So when you are identifying the resting motor threshold, we give 10 stimulus to a given area, particularly the motor area, and we look for contractions in the hand area, particularly motor contractions, either through the EMG or through visual contractions. If you are getting 5 effective contractions or 5 deflection in the EMG with a amplitude of more than 50 microvolt, we call them effective contractions. And there should be at least 50% of the stimulus need to be responded by the neurons. So every individual is having a specific resting motor threshold, and resting motor threshold is something which is a very dynamic phenomenon. It keeps on changing from time to time in a given individual. Like suppose somebody is deprived from sleep, the resting motor threshold will be low. Suppose somebody is taking benzodiazepine or any anti-epileptic medication, the resting motor threshold will be high. Suppose somebody has consumed alcohol last night, because of the GABA or glutamatergic activity, the resting motor threshold can be altered. So one need to estimate the resting motor threshold on regular intervals before delivering the TMS. And one good thing is, suppose you are doing it for a research purpose, it is better to do the estimation of resting motor threshold on daily basis. If you are doing it for a clinical purpose, maybe every 3 days or in a week, we need to estimate the resting motor threshold. What happens to the resting motor threshold in the due course of therapy? We all know that when we are giving electroconvulsive therapy, the threshold of the neurons keeps on increasing after multiple sessions of ECT. But here a different thing happens. When you are giving rTMS during the course of treatment, the frequency, the resting motor threshold gradually declines. So one need to be regularly monitoring for that. Then priming is another technique to optimize the effect of TMS. So priming is basically, suppose you are giving a priming for the high frequency stimulus. Suppose you are giving a priming for the low frequency stimulus, the priming technique is different. Suppose you are targeting priming for high frequency rTMS in depression. So you have to give a low frequency protocol over the left dorsolateral prefrontal cortex. After that, you have to give a high frequency protocol. So you do the priming with low frequency protocol for a subsequent high frequency protocol. Suppose you are giving low frequency rTMS for OCD and you want to do a priming, then you do a high frequency of 6 hertz frequency, 600 pulses priming over the supplementary motor area. Then you run the low frequency protocol. So a stimulatory protocol requires priming with an inhibitory protocol. A inhibitory protocol requires priming with a stimulatory protocol. This is the dictum. Theta burst stimulation is another modality of TMS where pulses are released in burst, not in pulses. So they are released in burst. So 3 pulses in a go. Then they are having a frequency of theta. The burst is released in a theta frequency. So theta frequency is ranging from 3 to 8 hertz. So classically theta burst stimulation releases the burst at a frequency of 5 hertz. So continuous theta burst stimulation and inhibitory theta burst stimulation are 2 types of theta burst stimulation. Continuous theta burst stimulation gives a inhibitory effect, whereas intermittent theta burst stimulation gives a stimulatory effect. So intermittent theta burst stimulation is almost similar to high frequency rTMS. Continuous theta burst stimulation is almost similar to low frequency rTMS. Then regarding combining different protocols. So we discuss about priming. Priming protocol is a combination of protocol, high frequency and low frequency protocol. Sometimes you have to do a sequential stimulation or a multi-site stimulation. Particularly, people do multi-site stimulation when they are treating patients with schizophrenia. The common multi-site targets are you target the left dorsolateral prefrontal cortex with a high frequency protocol followed by low frequency protocol over the left temporoparietal junction. So this is a sequential stimulation of 2 sites in a given session. You can do the multiple protocol for treatment of depression. Like you are targeting the left dorsolateral prefrontal cortex stimulatory protocol by giving intermittent theta burst or high frequency rTMS, then switching to the right DLPFC by giving a inhibitory protocol. So it is a sequential stimulation by using 2 different protocols. Suppose you are treating tinnitus, You can do a multi-site stimulation with a sequential different protocol. Suppose you are treating Parkinson disease, you can do the multi-site stimulation. So there are various conditions where you can do combination of protocols and use in a given session. Then coming to booster sessions. Booster session basically refer to the maintenance rTMS. It is basically aiming at preventing the relapse of the symptoms, particularly in patients with depression, OCD, schizophrenia. Commonly, people do the maintenance rTMS sessions. Multi-site stimulation that we have already discussed, then combining TMS with TDCS. This is another newer area of research where people started using TDCS and TMS simultaneously. TDCS can be used as a priming modality. TDCS is transcranial direct current stimulation. So there is a cathode, there is an anode. Cathode produces inhibition and anode produces stimulation. Suppose you want to do a priming not by using TMS, you can do the priming by using the TDCS. You have given a anodal stimulation by giving TDCS as a priming technique. After that, you have given TMS low frequency. So you stimulated with TDCS, then inhibited by rTMS. And vice versa also you can do. You stimulated with the rTMS, then subsequent inhibition therapy was being delivered by TDCS. So combining different modalities are also being tried successfully with safety ensured. Now quickly we'll talk about different evidence-based protocols. Depression is one of the commonest indications where rTMS is being used. Common target is right dorsolateral prefrontal cortex and left dorsolateral prefrontal cortex. If you are targeting right dorsolateral prefrontal cortex, you need to give low frequency or continuous theta bar stimulation. If you are giving a high frequency stimulus, then you need to choose the left dorsolateral prefrontal cortex. The commonly used frequencies, high frequencies are 8 Hz, 10 Hz, 20 Hz. Among these three, 10 Hz is the most commonly being used. It is being approved by US FDA in 2008. 10 Hz frequency, 40 pulses in a train, 75 trains, total of 3000 pulses, 26 second intertrain interval. So total of 37.5 minutes protocol, and it need to be repeated over 20 days for 20 sessions. Intermittent theta bar stimulation is an alternative to this high frequency protocol, which is being approved after 10 years of the first approval, that is in 2018. Here you can deliver the pulses over a period of 3 minutes by using the theta bar stimulation. Here 600 pulses are being delivered over a period of 3 minutes. So it is curtailing the duration of treatment. So it is more time convenient for the patient and as well as for the therapist. The response rate, many RCTs has been conducted. They found that with the active TMS, the response rate is nearly 3 times higher than the SAM TMS. Usually people have used a stimulus intensity of 80 to 120 Hertz, 120% of the resting motor threshold. So particularly if you are delivering low frequency rTMS, then go for a sub-threshold stimulus, maybe 80%, maybe 90% of the resting motor threshold. Suppose you are giving a high frequency, then go for a supra threshold, that is 110%, 120% of the resting motor threshold. So resting motor threshold, we have already discussed that for a given individual, resting motor threshold, you need to identify. Suppose you identified the resting motor threshold in my brain and you identify it to be 50. 50% of the output, that is 50 amplitude. My resting motor threshold is 50, which is corresponding to the optimal resting motor threshold, that is 100% of my resting motor threshold. If I need to receive a therapy at 120% of the resting motor threshold, then 120% of 50 will be 60. So we have to deliver that therapy at 60 amplitude. Similarly, if you have to deliver it at 80%, then it will be 40. The total number of sessions given in majority of the research ranging from 5 to 30 sessions for treatment of depression. There are several parameters. You can now you can use various parameters to predict the outcome of response. Parameters can be related to the coil placement, parameters related to the TMS parameters. There are some approved indication related parameters, mostly related to if you are giving a high frequency rTMS, then go for threshold or supra threshold. Pulse frequency if you are going for low frequency, then go for 1 hertz or less frequency, targeting the right dorsolateral prefrontal cortex. If you are going for a stimulatory protocol, use 5 to 10 hertz frequency, preferably 10 hertz frequency, targeting left dorsolateral prefrontal cortex. Considering the safety, you need to have a shorter intertrain interval for low frequency protocols and longer intertrain interval for high frequency protocol. High frequency protocol, more of left dorsolateral prefrontal cortex, low frequency for right dorsolateral prefrontal cortex. So it is more of a laterality related placement. So these are some already approved indications that are available online. You can refer to those indications. No need to remember all those things. These are given, all these protocols which is available. If you have a TMS lab, you can paste all those essential things in the lab so that readily you can refer to those things. What are the approved protocols? What are the coil positions? How to locate those important brain areas for different conditions that need to be a part of your reference manual in the TMS lab. There are various accelerated protocols that are being used for treatment of depression. Some of the accelerated protocols, they used high frequency, low frequency rTMS. People also used accelerated protocol using continuous and intermittent theta burst stimulation. Protocol duration ranging from 10 to 30 minutes. So various techniques has been used for identifying the targeting brain areas, particularly DLPFC. One of the commonest used method is 5 centimeter or 5.5 centimeter method. Dr. Shruti has already talked about that. You have to identify the vertex and 5 centimeter laterally. You have to take a point across the intertragal line. You have to mark that point. Then again, you have to take a point 5.5 centimeter anterior to that point. That is going to give you the dorsolateral prefrontal cortex. BeamF3 is another software that is freely available where you consider 3 parameters: nasion-union distance, intertragal distance, and head circumference to identify the dorsolateral prefrontal cortex. Neuronavigation is the most accurate method of identifying the dorsolateral prefrontal cortex, but you need functional MRI, and you need to take the skull configuration and superimpose that skull configuration with the functional MRI generated skull size, and you need to identify. Treatment dose need to be considered, identifying the motor threshold. So mostly the therapy is being delivered during the resting state, but now a lot of research are coming when people are using TMS in an activated state by engaging the patient in some cognitive task. So task-oriented, activated brain areas are being modulated. The recent approval of the accelerated protocol is the SAINT protocol, Stanford Accelerated Intensive Neuromodulation Treatment Protocol, SAINT protocol. This targeted the F3 location, that is left dorsolateral prefrontal cortex. 1800 pulses are delivered in each of the TMS sessions over 10 minutes, and 10 sessions given in a given day with a inter-session interval of 60 minutes. One session given, after 1 hour, another session is given, and over a period of 10 hours, 10 sessions are given in a given day. And over a period of 5 days, 50 sessions are being delivered. And you see the interesting outcome. If you see the acute response, the conventional rTMS protocol of 4 to 6 weeks, it gives a response remission rate of 30%. If you are giving a electroconvulsive therapy for treatment refractory depression over a period of 2 to 4 weeks by alternate day ECT or 2 ECTs per a week, then you get a response of 50% remission. But if you are using SAINT protocol by using intermittent theta burst stimulation, you get a remission rate of 80%. So we have something better than ECT now by using neuromodulation. But this protocol, though it is approved during the COVID time in 2020, but it was not replicated in multiple scenarios. People are carrying out multiple clinical trial to using the same protocol to see its efficacy. It is in progress. We can predict the response to rTMS in various psychiatric conditions. There are some measures by which you can predict that who are those individuals who are going to respond to TMS better, and who are those individuals who are going to respond to TMS not the result will not be that encouraging. So negative predictor and positive predictors that are already known from evidences. The predictors can be neurobiology related, like receptor related predictors, neuroimaging related predictors, like what is the metabolic activity in different brain areas, glutamatergic activity, glucose metabolism related activities, and the volumetric assessment, volumetric dimension of different brain areas. Then electrophysiological also you can predict, like before doing the TMS, you can do a EEG and you can quantify. Quantitative EEG can give you an idea about what is the different waveforms or different cortical activities in different brain areas. Accordingly, that can give a prediction about the outcome. TMS related techniques and various other concomitant antidepressant treatment and duration of depressive episode, all these parameters, they predict the outcome of response to TMS. Similarly, people used various level of evidences, identified various evidences with respect to use of TMS in schizophrenia, TMS in OCD, TMS in bipolar disorder, PTSD. So I'm just quickly skipping all those slides. So this is available in this article, that is effect of therapeutic use of TMS in psychiatric disorder, an evidence-based review. You can refer to this article. You will get the evidence, level of evidence, what is the target area, and what type of TMS strategy you need to follow for that, and what type of symptoms particularly improve with these interventions. Now coming to use of TMS and OCD, this is another area where TMS is being commonly used. Corticostriatothalamocortical circuit is being involved, so you can target the different areas. Common areas targeted are orbitofrontal cortex, supplementary motor area. Other than these two areas, dorsolateral prefrontal cortex and pre-supplementary motor area, dorsomedial prefrontal cortex are also being tried in patients with OCD. So recently we conducted a umbrella review of meta-analysis related to rTMS and OCD. Umbrella review basically refers to the systematic review of the meta-analysis. So it is still one step higher, the evidence of meta-analysis and systematic review. So this is the first umbrella review of meta-analysis related to use of rTMS and OCD. And we analyzed 12 meta-analysis in this study, and the common target areas are DLPFC, supplementary motor area, orbitofrontal cortex. There is a lot of heterogeneity in all the 12 meta-analysis that are being included. The thing is, initially people suggested that DLPFC may not be the good target area to deal with OCD. Non-DLPFC target like supplementary motor area and pre-supplementary motor area may be a better target. But subsequent evidences that support that, why the negative result were there with the DLPFC, because these studies were limited by small sample size. When they tried to replicate those studies with a larger sample, they found that dorsolateral prefrontal cortex neuromodulation is equally effective than supplementary motor area. So DLPFC, supplementary motor area are equal effective target. If you are targeting the dorsolateral prefrontal cortex, then target the left dorsolateral prefrontal cortex with a stimulatory protocol. If you are targeting the supplementary motor area, then target it with a inhibitory protocol. So maybe in low frequency rTMS, maybe continuous theta burst stimulation for supplementary motor area, intermittent theta burst stimulation, or high frequency rTMS for the left DLPFC. Now the deep TMS, ma'am is going to talk about the advance of TMS. Deep TMS is one of the advancement in the TMS procedures. H1 coil is meant for the major depressive disorder, H7 coil is for OCD, H4 coil is for smoking cessation. So deep TMS gives better penetrability, around 5 centimeter penetrability if you are using deep TMS. But if you are using a conventional TMS coil, the penetrability is limited to 2 to 3 centimeters. So in schizophrenia, people used rTMS, particularly targeting the left temporoparietal junction or bilateral temporoparietal junction by using a low frequency rTMS, mostly a subthreshold intensity. There is a dictum, like suppose if it is salient auditory verbal hallucination versus non-salient auditory verbal hallucination. What is salient auditory verbal hallucination? If auditory verbal hallucination is associated with some emotional component, yes, component of emotional distress. So that is salient auditory hallucination. Auditory hallucination may not be producing significant emotional distress. So that is non-salient auditory hallucination. People differentiated that presence of salience with auditory hallucination determines the laterality. Like suppose there is a salient auditory verbal hallucination, maybe the suitable target is right temporoparietal junction. If there is a non-salient auditory verbal hallucination, maybe the target is left temporoparietal junction. So this is how presence of salience decides which target need to be done, which area need to be targeted. We also wrote another interesting article. Can we predict the response to TMS when you are treating auditory hallucination in schizophrenia? There are a lot of evidences, like suppose somebody is receiving some anticonvulsive drugs that reduces the efficacy of TMS. Anticonvulsive drugs like valproate, lamotrigine, carbamazepine, if they are given for treatment of the comorbid affective symptoms, if anybody is asking any question to me, I can take the questions at the end of the session. Then low frequency rTMS with a high number of stimulation per day over the left temporoparietal cortex is another technique which predicts a better response. If you are doing a neuroimaging guided high frequency rTMS over the posterior part of the supratemporal sulcus, then that gives a better response. So these are various neuroimaging, frequency related, laterality related targets that predict the outcome of auditory hallucination treatment with rTMS. rTMS has been tried in patients with addictive disorders. Evidences support that it is effective in alcohol use disorder, tobacco use, cannabis, cocaine, stimulant use, opioid use. Many studies, they used single session of rTMS for the treatment, and many used the multiple sessions. It is always better to have multiple sessions, but multiple sessions, they give a relatively better result than the single session of rTMS, because multiple sessions helps in development of neuroplasticity. Then when you are using conventional TMS and theta burst stimulation or deep TMS, you need to choose different protocols. Deep TMS particularly gives a better penetrability, and it is FDA approved in 2018, and it is using the H4 coil particularly for smoking cessation. The target symptoms when you are treating an addictive disorder is mostly craving related symptoms, but it has been seen that those who are receiving TMS for treatment of addictive disorders, the total amount of substance consumed in due course of time significantly reduced. The duration of abstinence also significantly reduced. The cognitive symptoms or cognitive errors associated with the addiction, or the affective symptoms associated with addiction, they are also significantly reduced. People try to identify different predictors associated with response to TMS in addictive disorders, referring to EEG changes, dopamine transporter, dopamine modulation, blood oxygen derived different bold signals, and they predict it is in process. I didn't found any study clearly mentioning that these are the predictors that predict the outcome of TMS treatment in addictive disorder. Maybe you can write another article, you can submit to Global Psychiatry Archives. Professor Reiner, who is the editor-in-chief of Global Psychiatry Archives. So rTMS, when it is being used in substance use disorder, the common target areas are dorsolateral prefrontal cortex. It can be right, it can be left, or bilateral dorsolateral prefrontal cortex. Medial prefrontal cortex is another area. Insula is another area. Anterocingulate cortex, dorsal anterocingulate cortex. Particularly when you are using deep TMS, you can target insula and anterocingulate cortex, because these areas are particularly deep seated, and probably you require deep TMS with a better penetrability to have the therapeutic effect. Here I will close. We know that rTMS is increasingly being used for a variety of psychiatric conditions, and the success of therapy depends upon a large number of things. You need to choose appropriate patients for the rTMS therapy, you need to do a appropriate protocol, appropriate target area need to be selected, and you need to choose a protocol that is supported by good evidence backup. A lot of protocols are available when you are referring to the guideline. Recently, in 2023, Indian Psychiatric Society has also published a practice recommendation for use of rTMS for neuropsychiatric disorders. This article is being written by Dr. Sai Krishna Tikka, Dr. Sovit Garg, Dr. Alim Siddiqui, and their team. You can refer to that article. That is interesting article with all the evidence backup, when to use, how to use, why to use, and which protocol to be used for a given condition. Thank you so much. We'll take questions at the end of the